From the brainstem, a continuous stream of neural impulses branches out into the autonomic nervous system and cellular structures. This network functions as a dynamic biological manager, coordinating the body's internal environment. This system regulates physiological reality by calculating the precise rhythm of a heartbeat, managing digestion, and overseeing cellular replication without a single conscious command. Shamanic and Zen Buddhist traditions identified this hierarchy centuries ago, operating on the premise that physical reality and bodily health are downstream of cognitive perception. In the mid-1980s, Dr. Deepak Chopra demonstrated that mental states affect all cells in the body simultaneously. These findings identified a physiological connection maintained through neurotransmitters. The primary obstacle to systemic healing is the conscious mind, which acts as a critical faculty, a cognitive firewall that prevents direct instructions from reaching this somatic manager. Clinical hypnosis is a structured, procedural methodology designed specifically to bypass this conscious firewall and gain access to the mind-body operating system. Bypassing conscious defenses to stimulate healing is a methodology refined over millennia of human history. Evidence from ancient Egyptian medical papyri documents the use of sleeping temples and structured trance inductions specifically for healing. By the 1500s, medical practitioners like Paracelsus began mechanizing this process. He used lodestones to pass over patients, attempting to initiate healing by manipulating the body's magnetic states. A significant clinical shift occurred in the late 1800s when researchers successfully used deep trance to create a visible lesion on a subject's hand and then caused it to disappear. Pierre Janet was a key figure driving these early experiments, providing evidence that the unconscious mind could override and alter physiological tissue states. These historical milestones established trance as a measurable somatic state capable of physical alteration, providing the foundation for modern clinical frameworks. Dave Ellman introduced a structured, direct approach to clinical hypnosis, shifting the discipline toward a repeatable, measurable architecture. Ellman viewed psychological resistance as a conscious mechanism. If this firewall is engaged, it prevents therapeutic progress. To disarm this, he utilized a pre-talk phase. This conversation is designed to eliminate misconceptions and secure the subject's active participation before an induction begins. Ellman specified 4 prerequisites for a successful induction. The subject must consent, clear communication must exist, and they must be free from fear and reluctance. Establishing trust regarding the practitioner's therapeutic intent is the method used to satisfy the requirement for freedom from reluctance. A clinical induction begins with the active, informed surrender of the conscious mind's defensiveness. Milton Erickson employed a diametrically opposed methodology. He used an indirect, permissive style that relied on metaphor and distraction rather than direct commands. Both approaches navigate a depth hierarchy that starts from normal waking consciousness and descends into distinct stages of trance. Erickson's primary tool was utilization, the practice of taking any spontaneous physical behavior from the client and incorporating it cleanly into the induction. If a subject exhibits a natural eye flutter, the practitioner acknowledges it aloud. This act frames an involuntary physiological reflex as a suggested response. This creates a feedback loop of compliance. The conscious mind registers the physical reflex as true, and in doing so, accepts the practitioner's guidance. Erickson treated conscious resistance as a current to redirect. By validating what the body was already doing, he moved the subject into the first stage of light trance. Once light trance is achieved, advanced linguistic patterns are deployed to deepen the state by overloading the critical faculty. One method is the double bind. This provides an illusion of choice where options, like asking if a client will lose weight because they forget to eat or because they have no patience for heavy meals, both lead the subject to the desired hypnotic outcome. The double bind forces the conscious brain to expend its processing power evaluating the choices, leaving the unconscious vulnerable to the underlying premise. Multiple embedded metaphors is a linguistic architecture designed to cause complete cognitive overload. The practitioner begins a story, interrupts it with a second, and interrupts that with a third. These unresolved narratives stack in the conscious working memory. When the memory buffer is unable to track the details, the conscious mind goes blank, creating an unobstructed window to the unconscious. The core change work is inserted during this phase, bypassing critical filters. The final step is resolving the nested loops in reverse order, finishing story 3, then 2, then 1. This ties up the conscious loose ends, resulting in amnesia of the actual change work. Linguistic complexity acts as a targeted denial of service attack on the brain, neutralizing the firewall through the structure of the narrative. While permissive language is effective for light and medium states, pushing a subject into profound, deep trance requires traditional, direct methodologies. This pushes the conceptual framework down to Dave Ellman's fourth level, somnambulism. At this depth, the state is verified by highly specific, unfakeable physiological markers. These markers include sustained, involuntary fluttering of the eyelids and an undeniable radiation of systemic body warmth. Ellman's test for somnambulism is the number block. When counting backward, the client simply loses the ability to recall the numbers. When the numbers are gone, the client has reached the no-mind state, indicating total mental relaxation and conscious shutdown. Post-hypnotic suggestions rely on this level of depth to ensure they are forgotten by the conscious mind. When the suggestion remains outside of conscious awareness, it prevents the critical faculty from interfering with the intended change. Deep trance is a measurable, verifiable physiological baseline required to rewrite the body's operating system. Whether utilizing Erickson's linguistic mazes or Ellman's direct procedural shutdowns, the target is the same. Both pathways seek unobstructed access to the somatic manager to induce neurological and physical healing. This direct access requires stable baseline neurochemistry. There are strict psychiatric contraindications for hypnotherapy. Individuals suffering from schizophrenia, bipolar disorder, hysteria, or epilepsy are excluded from standard treatment. Treating clients with these conditions requires a formal, written medical referral from a psychiatrist, as hypnosis can destabilize fragile neural architecture. Hypnosis is a potent medical intervention. Its efficacy and safety are tied to rigorous boundary setting and patient screening. Hypnosis is not a surrender of free will. Even in the deepest stages of somnambulism, the unconscious mind retains a self-preservation instinct and can reject any suggestion that violates its core values. Modern clinical hypnotherapy is a hyper-focused collaboration between the practitioner's architecture and the patient's own physical operating system. This collaboration results in a deeply rooted healing pattern taking hold directly in the body's physical neural web. The linguistic and procedural architecture of trance enables the human body to engage its native capacity for self-repair. It is a systematic application of clinical techniques designed to facilitate physiological healing.